Hello and welcome to another episode of Every Possible Angle. I'm excited here today. We have a great guest, Dr. Eugene Golts. He's the surgical director of lung transplantation for the Division of Cardiovascular and Thoracic Surgery at the University of California, San Diego. Thank you for joining us, Dr. Golts.
Thank you very much for inviting me. It's a pleasure and a privilege.
Recently saw you up at the AATS MCS meeting in Toronto. It was great to hear your presentations up there. But I'd like to start by asking a little bit about yourself, about your journey in medicine, where you started in medicine, and actually a little bit about how you got into transplantation. I understand you actually started as a nurse anesthetist back in Ukraine before getting into transplantation. Can you tell me a little bit about the beginning of your medical career and how you transitioned to transplantation?
Sure. Well, I started out in Soviet Union, former Soviet Union, at the time, and actually always wanted to be a physician, but because of my nationality, um, was not allowed to do that. So I kind of had to find the back door into medicine, essentially. And so went to the nursing school and really liked the respiratory and cardiac physiology and anatomy. So kind of gravitated toward the intensive care and eventually became a nurse anesthetist. Um, but I never surrendered the dream to become of becoming a physician. Now, at the time, kind of like I was getting really frustrated with the system that we had, the political system and the medical system, all sorts of systems that we had in Soviet Union.
Yeah.
So I really wanted to immigrate, and I didn't particularly care where. So I figured that the first step is learning the language, and started learning English. And since I wanted to go into medicine, started reading a lot of medical journals that were published in English, and came across the article about the Barney Clark and the heart transplant, and got really excited about the prospect of potentially doing the transplantation and the thoracic transplantation. So from that point, I got bit by the bug essentially, and is the rest of my life is a long and windy road trying to get to where I want to be, which is in the space of the thoracic transplantation. And was very fortunate eventually to end up at UCSD and do what I do now. So yeah, pretty straightforward.
For you, maybe that's a fascinating story. It's amazing, and your passion and resilience to pursue a medical degree and not give up on that dream, and then transition into transplantation. Can you tell me the first time you were in a transplant? What was that like after reading about it, after pursuing this field for so long?
Um, well, I can only compare it to trip to Disneyland, I guess. It was great.
Yeah.
It was great. It was in the middle of the night, as it always happens or frequently happens. It was a very tired surgical team and very sick recipient. So it was normal transplant. um, it was extremely exciting to see the lungs working right there and on the operating table. It was amazing because I remember I remember seeing the explant of the organs and the new organs coming into to the operating room, and us unpacking and kind of like waiting impatiently to see the new lungs, and then putting the lungs in, and kind of like when they start ventilating, it was amazing. You just see the lungs expand, and all of a sudden we were able to come down on the oxygen, inspired oxygen on the ventilator, and down to essentially almost the room air, and the patient was doing great. It was remarkable. This is the patient who was on the deathbed before, and all of a sudden the lungs were working perfect.
And it's your story there. It's something that I've heard similar before from a lot of transplant physicians. That even as a medical professional who's understands what's involved in transplant, um, that moment of seeing, when you first get into transplant and seeing the transformative effect that this second lease on life, um, for these patients, it's so powerful, and the ability to take a patient who was, as you said, sort of at death's door, and provide them a completely functional new lung capacity. It's truly incredible, and I think that's a common sort of hook. Once you see that, it's incredibly powerful.
Yeah, it kind of it's interesting because you asked me about the kind of my experience in the operating room. The true journey starts before the operating room, because I uh, the patient that I mentioned, the first lung transplant I attended, was the patient that I was taking care of as a resident for quite a while, and get to know him, and it's just it's an incredible. I mean, it's an incredible feeling. I mean, you feel connected to the patient, but at the same time, it's very different from any other surgery. I always tell my patients, actually, this is sort of part of my spiel. I always tell my patients that the lung transplant is completely different from any other surgery that we perform, in the sense that in any surgery, there is always a life at stake. But in transplant, I feel, as a physician, as a surgeon now, I feel like I'm responsible for potentially four lives, because it's a life of the donors. Unfortunately, in current day and age, someone almost always has to pass for us to receive the lungs. And the life of the recipient, of course, the person who undergoing lung transplant, and potentially lives of two other people who are not getting the lung transplant, because this person on the table in front of us is getting the lung transplant. So um, I can't say that it brings up the pressure, but it certainly, um, I'm always in awe of the responsibility that is entrusted in us uh, by the donor family, by the um, recipient and his family, by other people on the list who trust in us to do the right thing. So it's actually it's very important for me to kind of like to think about it.
It, that's incredibly profound. That and the awareness of that responsibility, that weight of that this lungs organs, in like you say today, are such a scarce gift, and to treat everyone with the respect of both to honor that donor, uh, provide the best outcome as possible to that recipient, but even thinking about, even to the people who are on the wait list waiting, you have to make the most out of this one organ. If you've made this choice for this recipient, that there's a responsibility to make sure that it gets as much protection. And I think that's our team here, that certainly resonates, our belief of every possible advantage that it actually came from a lung transplant patient. And that was sort of the intent, was to look at every possible way we can help with preservation and improve how organs are honored in their journey, and as well as clinically protected for optimizing as best an outcome as possible. I'm curious, Obviously so that was your beginning at in lung transplantation. Now you're the surgical director at UCSD. You've been there for a few years, and the program's going through some transformation right now. Could you tell me a little bit about UCSD? We had talked about it when we were together in Toronto, but I'd love to hear more about the growth and the transition the program's gone through in the recent years.
Well, I mean, we're actually, interestingly enough, UCSD was one of the first programs in California that started performing lung transplants and heart transplants. Not the first, but one of the first. And so we've done it for years, and of course, we have quite an extensive programmatic experience. As it often happens with the programs, we've gone through ups and downs. And at certain point, relatively early in my career, we noticed that um, uh, we started to kind of to the innovation, the kind of like the progress sort of like the progress curve sort of leveled off. And of course, we really wanted um, to improve on that. So, with that in mind, we actually set out to change the way the program is administered. In a sense, um, at the time, we were very focused um, on outcomes, and I think this is very important focus for the program. Uh, but I deliberately, and my partner on the medical side, I'm very fortunate to have friend and a partner, the medical director of the program, Dr. Kamir Afshar. We kind of made a concerted effort to make the program very patient centric. Well, every patient in the program is treated very personally, and it does take a lot of time. It is an investment, but on the other hand, it really kind of like really helps to bring people on the same page, because the ultimate outcome is the patient, how the patient does. And we deliberately assembled the team of the uh, coordinators, pharmacists, physical therapists, nutritionists, social workers, financial coordinators, pulmonologists, and surgeons to focus on that. People who are interested in doing right by the patient. That makes it very easy to work and very easy to manage people, because um, ultimately everyone has absolutely the same goal. For Mr. Jones, Mr. Smith, Mrs. Lee to do well. And that kind of like that goal unifying, kind of like having one unifying goal is very helpful. The byproducts, of course, are outcomes, and we've done a lot of restructuring within the program um, to improve outcomes. We also try to travel, and we kind of try to collect the experience from other programs to see what other programs around the country and internationally are doing well. And we're not afraid to change our practice. Um, Again, keeping the individual outcomes for the patients their best.
One of the things you touched on there that I think is particularly unique in transplant is the team approach. More so than a lot of other areas of medicine, it takes a very large team to make transplant possible, but also the longevity of the relationship with the patient. It's not just a single surgery. You're, as you described, even from your first case, you're with the patient and sort of end-stage organ failure care for an extended period of time. You're considering many patients, and then you have to understand the environment the patient's going back into in terms of outcomes, in terms of care, in terms of social support, in terms of a variety of factors. Um, and I think the leadership and uh, mission alignment that you're touching on is so important. If the team is aligned, if everyone's pulling in the same direction and has the same goals, I have to imagine that makes an incredible impact in making such a large machine, such a large organization, be able to be impactful, to make progress, to continue to evolve. It seems like a critical part of what you've developed there at UCSD.
Yeah, no, I mean, kind of like the team is extremely important. You cannot overemphasize the importance of the team. And with that, it's quite interesting because with that comes a very, I mean, additional responsibility. And to be quite honest with you, as a physicians, through the whole training and career, we work within the teams, but in very few places, the team is more important than in a transplant because the care of these patients is so multifaceted. You have to serve, solve so many problems, so many issues. And yet, if you look at the medical training in everywhere pretty much, I mean, but certainly in the United States, there's very little emphasis on the training, the managerial aspects of training. We learn a lot about medicine, the physiology, the anatomy, the surgery, uh, but very little about management. So actually, I felt like I needed to go and get some more education. I kind of believe in education, so and UCSD was very accommodating, so I was able to actually join the MBA program at UCSD and completed it at the same time as rebuilding the transplant program. So it certainly helped a lot. Um, and but the team, the importance of the team cannot be overemphasized because it's just so complex.
And that's a really fascinating point. I think it's true in medicine, and a lot of careers. Your initial training really focused on this technical skill set for that vocation, but the needs, particularly in transplant, of collaborative work, of leadership, of managerial skill sets to advance a program, you don't get in your initial training. And so I think that's a really interesting a career progression to go through the MBA program in order to help advance and bring that program to the next level, to help lead that program. Did you find, and I guess I'm curious, in mentoring younger physicians as they're getting into transplant, do you talk to them about any of these, that the career path in transplant is a more collaborative, more team focused career path than other places of medicine?
I certainly try to mention it and encourage them. I mean, as I mentioned before, I'm a strong believer in education. So whether you're studying medicine, transplantology, or the business or managerial aspects of the trade, it's all important. Um, Now, our trainees, of course, have very limited amount of time.
Right,
So we
right.
try to focus on the expertise. I'm a just a recent graduate of the MBA program, but I'm a sometime graduate of the medical school program and the residency program. So I have a feeling that my experience in surgery and particularly lung transplant is somewhat unique. So I try, of course, to kind of like give them more of that or share with them more of that experience, but I encourage them to learn, and I try to answer the questions as they arise, and kind of point a few things along the way. I mean, you cannot kind of like transplant your knowledge into someone else. You can only give the trainees the idea of what to look for and what to work on.
In terms of continuing and being lifelong learners, you mentioned about how your not just you, but your program travels to conferences to continue to learn from other centers, learn new techniques, new approaches, and keep with the purpose of the focus on outcomes and focus on the patient. Um, in particular, in lung transplantation, outcomes historically have been a challenge. It's been a long road to improve outcomes in lung transplantation. Uh, Compared to some of the other solid organs, there's additional challenges. Can you tell us a little bit why lung has had more challenges in terms of transplantation than say kidney and heart in terms of long term outcomes?
Well, I mean, I think the lung itself is incredibly complex organ, and it's very immunogenic. So from that standpoint, it, it is always an uphill battle of trying to combat the acute or chronic rejection, um, or resulting diseases. So I think this is somewhat unique. Number one. Number two, the lung is continuously exposed to environment, um, as opposed to other organs. So mm, that's kind of like it's very challenging to manage it long term. So uh, for me, it starts with the moment we make a decision to go for a transplant. It starts with organ preservation because that affects the early outcomes and affects it probably affects late outcomes more than anything else that we do.
Lungs are, like you said, extremely unique as most other solid organs are internal organs. They aren't exposed to the external environment, and lungs are your primary barrier against infection, against respiratory disease, to the outside worlds. It's one of the few solid organs that really is that immune barrier, and so they're going to have a stronger immune response. And at the same time, you're trying to avoid the sort of conflict between the recipient and the donor organ immune systems. Uh, I think exactly like you said, the transplant journey and preservation, minimizing sort of the risk of inflammatory insults is going to be critical towards having a good initial transplant experience. And I guess too, sort of the landscape of organ recovery and organ preservation. There's a lot of change going on right now. Just the organ allocation system in lung recently changed from the what was called the LAS score to the CAS score. Could you tell our audience a little bit about what that change is and how that in practical matters has affected a program like UCSD?
So the certainly. So starting with an allocation score, it's an attempt to kind of like to level the playing field for all the or give an equal chance to all the transplant recipients uh, around the country to have equal access to the organs. And the LAS has been around for quite a while, and we noticed that there are certain groups of patients that were somewhat disadvantaged. Number one, and number two, I think there was a growing realization that what we do, this whole um, idea of transplanting organs is not the exercise in seeing whether we can do it and the patient can survive. Uh, the idea is to provide the meaningful survival for the meaningful amount of time for people. So, in the lung allocation score, for example, the focus was on the 1 year survival. The The new system looks for longer term survival, extends it to kind of like to longer term survival, because we don't want people to survive just 1 year. We want them to have a long and happy and meaningful lives and be able to do what they do. So um, that was one kind of like the one change was in compared to the LAS and CS. The other idea was the fact that with improved preservation, we can travel further. We can push the envelope. We can open more organs to more recipients rather than making it more regional when certain regions in the country were uh, privileged or had access to more donors, and then some areas of the in some areas of the country there was less donors. The idea is to level the playing field a little bit. On top of that, there were subtle changes or subtle differences in what makes a patient a good candidate or what makes a patient more likely to not do well on the transplant list for a long time with regard to the diagnosis. So that has changed significantly in the new allocation. The transplant complexity, the complexity of the cases has gone up dramatically. Um, Before it was a double lung transplant, and now I'm going to be doing tonight a lung transplant, double lung transplant, ASD repair, atrial septal defect repair, tricuspid valve repair, and the cabbage. So on the patient. So what that means, I mean, we can do those things technically and programmatically. We can take care of these patients, but what it does, it lengthens it lengthens the amount of time these patients are in our care, and especially it prolongs the ICU stay, which is very expensive. So the complexity has gone up, but the price of the transplant has gone up. So we're always actively looking for things to decrease the kind of how to cost contain in this respect, and we're always looking for ways to bring the cost of transplantation down. And one of them is, of course, decrease in the ICU stay. If we can if we can decrease the amount of days patients are in the ICU, that is amounts to substantial savings. And usually it's not the run of the mill transplant that kind of drives this. It's those outlier cases like I just described right now that make a difference. So if we can take the ICU stay from 10 days and down to 2 days, that is a very significant price saving.
It does tend to be the outliers that drive overall program research burden, and I think that's absolutely and to some degree what you're saying, that with the shift in terms of CAS, which helps prioritize medical urgency, the highest medically urgent recipients, means more frequently you're dealing with patients that are far more complex surgically, and one of the best ways to sort of have predictable costs, contain outlier approaches. Not only is that good for the patient to not have a long post-operative course and have complications, but that's important for the program. That's important for the sustainability of transplant to be more cost-effective in the way that you approach, that you're able to handle these cases. And you touched on that sort of at the same time as the allocation score has caused longer distances, which is both a challenge because historically ischemic times were tried to kept very limited. That the time out of body time is trying to keep really limited, which limits distances ability to travel. The goal, it both created a challenge at the same time as the allocation score sort of enabled access, leveled the playing field, as you said, to a larger sort of a donor pool. to help transplant centers access the sickest patients, access the organs they need. But at the same time, there's been a lot of change in sort of the philosophy of preservation, which has helped enable programs to take advantage of that larger donor pool and access those longer distances and do so in a safe way, using new technologies. What has been your view of sort of the changing landscape on preservation?
Well, I think the major breakthrough or the major change is the change in the understanding of the temperature. And the fact that the new recognition of the fact that probably the pressure was in the tracheobronchial tree or was in the lungs is also important for the maintenance of the organ integrity. And with that, especially it started with the temperature. I think major change has happened with the temperature because there's been kind of quite a few publications, particularly from Toronto, um, uh, that focused on the fact that the temperature, the original storage of ice on ice, is probably not the optimal temperature to store the lungs on, and the temperature somewhat higher is the more appropriate temperature, um, and that I think is taking the lung transplant world by storm, um, for various reasons. Um, so that's been very important, but somewhat less studied, but not less important, I don't think, is the fact that the constant pressure preservation of the lungs seems to actually do quite a few good things for the organs. So those two changes, I think, help us to travel further or build the courage to travel further, to spend more time for the lungs in storage. And the needle is been moving, but it certainly has not stopped. So I would imagine that the 24 hours is going to be the next frontier.
Absolutely, I think there's been without a doubt some very big shifts in the space, and but it's I don't think it's over. I think there's continued innovation happening, continued on the medical side, on the surgical side, technology trying to bring new ways to both handle the challenges of changing landscape, changing allocation policies, but also take advantage of them and help serve patients better. This is again a place where lung is a little bit unique. Other organs aren't full of air, full of oxygen when they are transported, whereas lungs are transported inflated. They're stapled off, and so historically, much like temperature wasn't monitored, it was organs were placed in ice and just sent on their way. Now we monitor temperature very closely on transplanted organs, but airway pressure also wasn't monitored, and particularly with the changing landscape, we're seeing more and more air travel, and like a bag of chips going up in a plane, you see pressure differentials when you go up and down. A contained space will expand if you go up in a plane, and so I really enjoyed actually at your presentation at AATS. You presented on some constant airway pressure management during transport, and you likened it towards or scuba diving, which is one of your hobbies and one of your passions. Can you tell us a little bit about the analogy you use of scuba diving to this airway management?
Well, scuba diving, I always thought that the scuba diving, kind of like a theory of scuba diving, is the most important part is management of the pressure and within the lungs, kind of like, and the idea of equaling the inhaled pressure to the ambient pressure in the environment. So that's kind of I've also seen, unfortunately, kind of like quite tragic events when that rule of managing, or equalizing the pressure to the pressure of the environment, kind of like how it backfires, or kind of like it's a rapid uncontrolled ascent. It's called. If that happens, the consequences for the scuba divers are dire. So, um, not that I think about it all the time when I'm underwater, but it seems like it occupies a significant amount of my attention. Um, I think it's incredibly important because even at the um, at the sea level pressure, there are changes in lung pressure, in pressure within the lungs when it's a sealed system, when the trachea is just stapled off over time. You can see it more pronounced. The higher percentage of oxygen in the mixture of the inhaled mixture, the more significant the drop in the pressure within the lungs. So it's not unique with the changing in altitude and changing the ambient pressure, but it certainly is very pronounced when you kind of like when you take a flight and when you go up on the plane, the pressure around in the cabin, the pressure decreases. The pressure decreases to that, they believe, 8,000 feet, equivalent of the 8,000 feet elevation. The when So lungs from that standpoint are experiencing expansion, which is can be quite harmful. On the other hand, when you land, when the plane altitude changes, when the plane starts to land, the lungs are being squeezed up, essentially. So to me, that is kind of like contradictory to what we're trying to achieve, which is a stable system. So interestingly enough, again, like there's research on that, and you can see the spikes, significant spikes in the pressure in the simulated flights and simulated lungs. It's been tested in animals, in animal studies, and they've been proven in animal studies. So um, managing the pressure, I think, is very important.
It's interesting. In some ways it's something that we take for granted, because normally when you can breathe in and out, going up in an airplane or even over time, that pressure is controlled. When there's excess pressure on the lungs, you can breathe out and exhale and equalize that pressure, inhale. But in certain situations, scuba diving, you have to more consciously think about that. Make sure you keep breathing so that you can manage those pressures. And similarly, it's something that hasn't been monitored, but is something that we're taking more looks at, more research at, sort of the effects when lungs are in transport and they've been stapled off, and whether or not that equalization of pressure is not happening and what the effects are of that, versus when it's under a controlled airway pressure system.
No, I agree. I mean, it's kind of like in scuba diving, what they teach you is basically you're always either inhaling or exhaling, but the bottom line is as long as you keep your mouth open, you're gonna you're gonna equalize. So what we do was a standard preservation, kind of like we staple the trachea so the mouth is shut.
Yeah, yeah.
So that's kind of we're just trying to figure out the way to keep the lungs inflated, but at the same time, so to speak, keep the mouth open.
I think that's an exciting pivot, and I think the field, it's like you were speaking of, these meetings where we can travel, we can meet with each other to discuss new ideas, whether on the technology side, medical research, to advance the field. I think that's key, because their challenges still are real in this space in terms of outcomes and that patient focus that you've really developed that mission at UCSD. I think that's a true importance of the field, is that we work together to continue to look at all the ways we can bring new innovation to patient care and organ preservation. I'm curious for you, where do you see sort of next steps in lung transplantation, and what is exciting for you in the field, or what is a challenge that you see that's coming up?
Well, I mean, I think um, the challenges abound. So with a new allocation score and us able to travel further, there very significant financial burden is placed on the institutions, uh, because now, whereas before we were largely limited to a local procurement, which required essentially a homegrown team and a car, or maybe helicopter for a short ride. Now we're looking at traveling in some instances across the country, or in a different country. So logistics of that, um, is an added level of complexity, and it's certainly financially, it is certainly places puts the burden on the transplant team, and it ultimately um, passes on the to the consumer, to the patients as consumers. So figuring out how to do it in a fiscally responsible way is, I think, is also very important. So that's one certain challenge, because the air travel adds up, and kind of from an environmental standpoint. I mean, now we're traveling on jets, and we're using the, kind of like, it uses a lot of fuel, and certainly increases the carbon footprint of, if I may, um, of the transplant enterprise. So that's one. Um, the other one is trying to, I think we're moving in the right direction and increasing the amount of donors available to our patients. But I think the next step would be to try to resuscitate the lungs, because right now we're pretty good at um, taking the lungs that are good and keeping them good. We're relatively good at taking the lungs that are not perfect but usable and using them. What we have not figured out how to make the lungs that are not usable at the time when we look at them, and how to make them better. And I think that improving the quality of the donor lungs, because we ultimately, kind of from the realistically, what we're doing from the medical standpoint, from the science standpoint, is very important. But from the epidemiologic standpoint, the transplantation in general is rather trivial. Um, there probably by a factor of 100, we can serve more. We need to serve more people than what we're doing right now. So we need to figure out the way to expand the donor pool dramatically. And I think the next frontier is taking the lungs that are not good and resuscitating them, um, to make them usable.
I think these are fantastic points. I think they're huge challenges in the field that we need to look at, because at the end of the day, you're right. Organ transplantation is serving a smaller population that needs it. Like you said right at the beginning, there's not just the one patient who's getting the transplant, but the two that are waiting. And the way that we can take a look at innovation to expand access, reach more patients, I think that's going to be absolutely critical. And I think also, as you said, looking at it clinically first is without a doubt the most critical piece, but we do have to consider our larger role in the healthcare ecosystem and even the whole global ecosystem in terms of these transplant is a resource intensive medical procedure, and the shift to the recent CAS score allocation system it's done amazing things in terms of waitlist and waitlist survival, getting patients transplants faster. Has helped programs like yourselves grow, especially leveraging new preservation technology. But at the same time, it is increasing the use of private aviation, private aircraft, charter aircraft, longer distances more frequently, which has a cost to the system. It has an environmental impact. And so, looking at innovations and ways we can use these extended ischemic times to look at alternative transport methods and new approaches to enable transplantation and do so, like you said, in a fiscally responsible way so we can serve as many patients as possible. I think those are big challenges that we're excited. I think there's a lot of opportunity to come up with new innovation. I think there's some interesting initiatives happening right now to address some of those challenges. But at the end of the day, we want to be able to serve more patients that we possibly can. So I think that's so true. We got to think about, like you said, 4 potential patients that are involved with every transplant. So I think that's a really important insight. So thank you so much for sharing your time with us today. This has been a wonderful conversation. I truly appreciate it. And thank you for sharing everything that you've learned over what is a really fascinating career. I truly appreciate it.
No, thank you very much. It's delightful to be on this podcast.
And thank you all for joining. Catch us next time on Every Possible Angle.